I want to thank everybody for joining us today for this talk on patient-centric approaches to bone healing. My name is Bob Zura. I'm an orthopedic trauma surgeon in New Orleans, Louisiana, and looking forward to talking on this topic with you. The program information for today, this is provided by the North American Center for Continuing Medical Education. It's an LLC and it's an HMP company. And this program is supported by an educational grant from BioVenus. We have some specific learning objectives for today's talk. First, we're going to examine local and systemic factors that promote and inhibit fracture healing. We're going to explain the science, the mechanism of action, and the evidence for low-intensity pulsed ultrasound on bone healing. We're going to investigate the impact of compliance or non-adherence on medical costs and clinical outcomes. We're going to explore case studies illustrating clinical outcomes of fracture healing treatments. We're going to start with some very basic fracture healing tenets. I would imagine most everybody in the audience is familiar with these, but we'll walk through them quickly just to make sure we're starting at the same point. And I think it's important to remember that fracture healing is a natural phenomenon, and often our job as physicians is to merely stand by and watch nature take its course, and that we should not interfere to cause problems. We're going to start with normal bone healing first, and I'm going to start with a case example. And this is just a case from my practice from a few years ago. This is a young patient who sustained a fracture to their proximal right femur. And I think you could call this a peritrochanteric or a subtrochanteric fracture. I would probably call it a peritrochanteric fracture that requires open reduction internal fixation. And that's what we did. We proceeded to treat this patient with a intramedullary nail in a recon type implant. I feel that our reduction was adequate, and our goal again here is to hold the bone in place while nature does its job. And this patient quite quickly went on to make callus to heal their fracture and to return to normal function. And as I stated before, Voltaire said this better than I did. The art of medicine consists of amusing the patient while nature cures the disease. Now, we did intervene in that femur fracture to place a nail. All that did was hold it in place while nature healed the fracture. And how did that fracture heal? That fracture healed by secondary healing, but let's review primary and secondary fracture healing. Primary fracture healing is actually not the most common, nor the natural process of fracture healing. That would be secondary or callus formation. Primary fracture healing requires an anatomical reduction of the fracture ends. There needs to be no gap, and there needs to be stable fixation. And often that stable fixation should also include compression of the fracture ends. And when these requirements are fulfilled, healing ensues in a primary method, and that's also a method of cutting cones. So very simply, the bones heal in the same way that they remodel. So osteoclasts will form the cutting cones, and osteoblasts will follow in and make new bone, and that fracture heals without callus. It heals in a primary fashion. Now, the example we gave was secondary fracture healing, and this is the most common form of fracture healing. It's what most of this audience should be familiar with. In secondary fracture healing, both endochondral and intramembranous healing occur. It does not require rigidly stable conditions, and callus formation forms. And in fact, you don't want it to be overly rigid. You're trying to find that perfect balance of stress and strain so that there's enough motion to form callus, but not so little motion that it doesn't heal, or too much motion that your implant or the fracture can't stay aligned. We have a cartoon here that goes through the 4 stages of bone healing that you get with secondary fracture healing. Again, when the patient breaks, there's an acute inflammatory response. There's a hematoma that forms. And assuming that everything is proceeding in the natural course, it then goes to that top right position. You get a cartilaginous callus formation, so that hematoma sort of remodels into cartilage. And then you get to the bottom left and you get ossification of that callus. So that callus background all of a sudden starts showing up on x-ray as bony healing. And you get that nice, robust football-shaped callus. And then you go on to bone remodeling in the normal stages of bone healing. And that's where the bone, through Wolff's Law, remodels itself, similar to primary fracture healing, and gets back to a more normal shape. That cartilaginous callus formation truly is a key feature of secondary fracture healing and fracture healing. You end up getting endochondral formation between the fracture ends. This brings some stability to the fracture, and then it will ossify secondarily. And the generation of this callus is dependent on the recruitment of mesenchymal stem cells. And this will be a bit of a theme throughout the talk. And as we get into deeper into the talk, talking about low-intensity pulse ultrasound, some of these same stem cells, some of these same growth factors will come up again. That's why I want to give you the basic science background here in the talk. So again, here is just a bit of alphabet soup demonstrating the recruitment of mesenchymal stem cells, and then the factors that come along with them. And some of those you're familiar with, like platelet-derived growth factor, TGF, which is transforming growth factor, IGF was insulin-like growth factor, and then BMPs, which is bone morphogenic proteins. I think that you're familiar with that. But again, so these cells come in, they're pluripotent, and hopefully in this setting, they become cartilage and bone to allow for fracture healing. Critical to any of these processes to occur normally is that we have blood supply and revascularization. So again, you need that initial hematoma, you need a perfused fracture, and then some of these stem cells and some of these factors will recruit new vascular ingrowth, which brings further ability to bring in more growth factors and remodeling of the fracture. So you need factors that bring in new blood vessels as well. That endochondral cartilage, that cartilage callus, then needs to become bone to achieve bony union and to achieve callus formation. And that primary soft callus, that cartilage callus, is resorbed and replaced by a hard bony cartilage. A cascade of factors initiate the resorptions of this primary callus. So again, very similar to the response to fracture, bringing in stem cells and growth factors. We need that for the continuation of secondary bone healing to go from cartilage to bone. I've heard it pronounced WNT, but the WNT family of molecules helps to regulate the osteoblastic bone formation. And again, you want those factors to be present, and you need blood vessels to get them there. And this is all a balance. This remodeling of bone requires that balance in the cutting cones where the osteoclasts are resorbing bone and the new bone is being deposited by the osteoblast. Very similar to when the cartilage is going away, but as you remodel, you need osteoclastic and osteoblastic driven by these factors again. So that was just a nice brief history of normal bone healing, again, focusing on secondary healing and callus formation, and some mention of the factors and the cascade of events that has to happen for that to happen normally. As orthopedic surgeons and as practitioners who take care of people with broken bones, we also know that sometimes it doesn't go as well as we would like, and we end up with abnormal bone healing. And we're going to spend most of the day talking about abnormal bone healing and non-unions and options there. So when doesn't it go right? I'm going to give you a case. This happens to be from a colleague of mine, Dr. Mehta, who's a world-class orthopedic surgeon in Pennsylvania. I didn't choose his case because I don't have them that don't go well. It just was a nice case that he'd put together previously for us. And I thought it gave a good example of when it doesn't go well. This was a 31-year-old female, fell and slipped on ice and had an open tibial shaft fracture, something most everybody listening is taken care of. And here are the initial x-rays. Again, clearly not a terrible soft tissue injury on the plain films, a short oblique fracture that Dr. Mehta did an irrigation debridement and an early internal fixation with anatomic reduction with an intramedullary nail. I'll spare some of the paths that get there, but we've all had this happen to us in our career where things don't go quite as planned. And this patient, unfortunately, was likely infected, wasn't healing, required hardware removal. And I think once we start to see a frame like this in place, we know that things are not going down the path we like. The fracture doesn't exhibit callus formation, and in fact shows a little bit of resorption. We've all been here, and we all don't like being here. She has draining from those pin sites. There's no callus. Her soft tissue's poor, and she's infected. So unfortunately, we're going down a path that doesn't appear to be a quick primary or secondary bone healing. Here you can see they've resected the bone ends due to infection, placed an intercalary spacer with antibiotic cement to get stability and a pretty simple frame. Here's just a picture of that clinically, an antibiotic nail with some antibiotic spacer around it, attempting to get to emasculate. You can see her poor soft tissue envelope here as well. And unfortunately, at 14 months after injury, this is where Dr. Mehta and his patient ended up. So fracture did not heal. It did not get secondary bone healing and ended up with a below-knee amputation, unfortunately, in this case. And there could be a great number of factors that contribute to that. And we want to investigate today some of the paths that get us there and some of our treatment options to potentially prevent this type of outcome. So when does fracture healing fail? What are the causes? What are the reasons why the first fracture went on to heal so nicely and the second fracture didn't? I think we all know inherently some of this is patient-related, some of this is surgeon-related, and some of this is probably a bit of a roll of the dice and luck. So I'm going to try to define non-union for you, and I think that's a bigger and a more challenging question than perhaps you've considered before. Now, the FDA defines non-union as 9 months of elapsed time with no healing progress for a 3-month period. I think there's some real challenges with this definition. I think it's subjective. I think it's arbitrary. It's the same for all bones. So would we expect a tibia and a femur to heal in the same amount of time? I don't think many folks would. And it's the same for all ages. An 18-year-old and an 80-year-old, should they heal at the same rate? Can we define them as delayed union or non-union at the same time? I think not. So I think this is quite a poor definition that the FDA leaves us with. So I don't think we're able to define non-union clearly that everybody agrees on based on their definition. Most trauma surgeons have a more pragmatic definition of non-union. I think they would define that as a fracture that has no potential to heal without further intervention. The problems there, however, are when can you decide that? Perhaps a soft tissue envelope so bad at day 1 that you think it's not going to heal, but I don't think that would be appropriate to call something a non-union on day 1. Perhaps other surgeons, or if it's your own patient, you may wait longer thinking that it's going to heal. So I think we're a real problem with when you apply that definition. So I'm going to postulate or present that I don't think we really have an acceptable definition of non-union. Think about the implications for that. It makes it very difficult for us to discuss with patients, to discuss with insurance companies, to define it for surgeries, and to define it for research. So it's challenging. And if you can't define it, you see what I put there as the paradox. If you can't define it, how can we even study it? And as we get to some non-union studies later, I want you just to recall this. Do we all agree on the definition? And how can we do great non-union research? So if we can't define non-union, can we at least define the incidence or prevalence of non-union? Do we know how often it occurs? And just as in background here, I'm going to use prevalence as we go forward, and I'm not even sure it's totally correct, but it's the way the literature that I'm quoting reports it. But prevalence tells us how widespread a disease is in a population. Incidence refers to the number of new cases of the disease in the population in a year. And in this case, the disease is non-union that we're talking about. So prevalence would be all the non-unions. Incidence really would be the new cases each year. In studying the etiology of a disease, it's the incidence that's more important. So I opened Rockwood and Green's, and this is chapter 25 on Rockwood and Green, and it's principles of non-union treatment. So this is all non-unions. This is not any particular bone. This is just their general overview chapter of non-unions. And you can see that they quote here, failure of an acute fracture to progress to timely union may be caused by a myriad of factors leading to an estimated prevalence of 2.5%. So one of our primary fracture textbooks is saying non-unions happen about 2.5%. So where do they get that number from, and what bones are they talking about? So their reference to that, there's that same quotation at the top from Rockwood and Green, the 7th edition, and their reference is from Milan's paper in Injury in 2007. And Dr. Sen's reference goes back to Dr. Pfeiffer's paper in JBJS in 2006, so a fairly recent reference. And what Pfeiffer and their group looked at was they looked at 22 series looking at 5,000 fractures, which is a large number of fractures, and they found out that the non-union rate was 2.5%. The combined prevalence of delayed union was 4.4%. They used 21 references, and you'll just see as I go through these next few slides, these are just some of her references. You'll see that references 1 through 4 are all the tibia, 12 through 20 are all the tibia, and 21 through 28 are all the tibia. So, and one is even a free vascularized bone graft, not the tibia. So their references, and again, the general overview of all non-unions, they really are giving us a vast majority of tibial references. So do we truly understand or know the incidence or prevalence of non-union in all bones? And I would argue that we do not, based on this reference, and we do not based on these papers alone. So unfortunately, I think we're left at a point here where we cannot define non-union universally. We can't define it in a way that's accepted by all surgeons, and we can't define it in a way that's accepted by all insurance companies, and we can't define it in a way that allows us to perfectly study it. That's a real challenge. And we don't even know the prevalence of non-union for all bones. So I think that's why a lot of us tend to use anecdotal and experience-based information on predicting non-union or advising patients. But clearly we know what causes non-unions, right? I think as surgeons we're all quite confident in that, and I want to delve quite a bit deeper into that literature. And unfortunately, I'm going to argue again that we don't know it that well. I think there's some factors that we know are associated with poorer healing and thereby higher rate of non-unions. Certainly open fractures, and open fractures are a spectrum. And this picture here is, a 3B or a 3C or perhaps even a near complete amputation. As you get higher energy fractures with more bone devitalization, more severe associated soft tissue injury and bone loss, I think that's fairly well established. That's a high risk factor, a local risk factor for non-union. Unfortunately, in Dr. Mehta's case, we ended up with an infection. Infection is a risk factor for bones to not heal and to go into non-union. These are fairly well established and I think fairly well accepted, so we won't argue those. Now, you can also have a closed injury, and this is clearly a photograph of a high Scherney grade. So it's a closed injury with massive soft tissue injury. Do we know the effect of different Scherney grades? So can we even quote those reliably in the same manner? So soft tissue injury here, but a different type of soft tissue injury. I don't know that we know how this magnitude of injury impacts non-union. And then we get to systemic factors influencing non-union. And I think these biologic factors are perhaps not as well understood as we think. I'm going to walk through a couple, and then I'm going to walk through some literature for us. Smoking and nicotine. I imagine every fracture surgeon at some point in their career has asked their patients to stop smoking or to not use nicotine to increase their chances of healing. Perhaps this works through decreased blood flow and decreased oxygenation to the bone. We talked quite a bit earlier about needing vascularity and increased vascularity. So if you do something that decreases that vascularity, you may increase your risk of non-union. Perhaps biochemically it works by inhibiting alk-phos and collagen production. And you need that collagen production to make your callus and to make your callus bony and hard. Perhaps it inhibits collagen deposition. Diabetes. Patients with diabetes we feel are at high risk for non-union and poorer healing. Perhaps this is because it's a peripheral vascular disease, small vessel disease, that you're not getting blood flow to the end unit, which in this case is the bone. Perhaps it's due to peripheral neuropathy and patients not having as much protective sensation. Perhaps they're putting too many forces across their fracture and leading to instability and too much motion at the fracture, and they don't heal. I know NSAIDs have been a great concern for potentially influencing fracture healing. There's been some change in the pendulum recently on this, but I don't know that we know definitively if they're problematic or not. They impact prostaglandin E2 inhibition. There is a correlation between NSAIDs used for more than 4 weeks in non-union, and COX-2 inhibitors may inhibit fracture healing more than other NSAIDs. How does this compare to opioids? How does this compare between the different NSAIDs? I don't know that we know that. In osteoporosis, perhaps this is a biologic risk factor for non-union. You get altered bone metabolism, delayed callus maturation, delayed fracture healing. Just a cartoon there of what the bone matrix looks like between normal bone and osteoporotic bone. But perhaps these are factors that lead to non-union. Maybe that's just a surrogate for age, or maybe it's the other way around. But I think that many of those are factors that we've all been quite comfortable with to some degree or another in our practice, and I want to dive into that a little bit more. But was any of those topics, were they evidence-based? And I think it's not as well based in the evidence as we may realize, and I want to walk through that literature for this audience. This is just a paper we put together for JBGS Reviews looking at biologic risk factors for non-union of bone fracture. And our assumption was that many risk factors for non-union were well supported in the literature, and we talked about those early on. What fracture, the fracture site itself, surgical treatment, the bony displacement, the type of fixation, treatment delay, comminution, inadequate treatment, wound infection, those sort of local factors. However, our systemic review suggests that patient-related or biologic causes may not have been as well understood as we wanted. So I think when I was talking earlier, the open devitalized fracture, pretty well understood in the literature, but the smoking and the NSAIDs and the other biologic factors may not be as well understood as we thought. And I'll argue that the non-union literature is actually quite poor. So again, from that same paper, we did a systemic review of PubMed, and we chose to go back 20 years. We chose that sort of randomly, but you have to pick at some point where you're going to stop pulling articles. A couple things to note: we found 361 articles looking at non-union from 94 to 2014. We published this. 154 of the articles demonstrated positive association, so the factor they looked at was causative of non-union. However, 122 demonstrated negative association, so the factor they were looking at was not causative of non-union. We were happy to see that interest in non-union has increased recently, meaning there are more articles, and if you look at that graph, you can see the number of articles per year is going up. So we feel that by looking at that, we found a sweet spot for the number of articles we looked at. And the average number of about 188 patients per study that we looked at in this study. So what did we find? We eliminated bones that were only studied once. I didn't think there was enough literature to know about that particular bone. And 253 of the articles examined the risk for non-union. 45 of those were prospective, and we'll talk about that again. So here is just a list, and it's a very busy slide. I'll give you some time to look at it. But what this is, in the last 20 years, this is the prospective studies addressing non-union in these bones. So if you look at find your favorite bone on the left, and then we can walk across. And let's just pick one here. We'll look at the tibia. I'm a trauma surgeon. I don't like tibia fractures because they don't heal sometimes. So there's 34 studies in the last 20 years looking at non-union in the tibia. Only 5 of those are prospective. Move down to scaphoid. Last 20 years, only 15 papers on scaphoid, but only 2 of those are prospective. So you just have to, evidence-based doesn't mean it has to be prospective, but as we want higher and higher levels of evidence. So I think this is clear from this chart that the amount of prospective studies looking at non-union is actually quite low. And unfortunately, I think that means that our literature is poor for non-union. Now we're going to look at This is an even busier slide for you, and this is the number of studies in which each potential risk factor was evaluated, and again from those years 94 to 2013. And you can again pick your favorite factor on the left. If you just go down two levels to age, you'll see there's 62 studies that looked at age and non-union. 38 of the studies had positive outcomes, meaning that when they looked at age specifically, they thought it was causative of non-union. However, 24 of the studies said that there was not an association, and they were negative outcomes. So 61% of the papers looking at age said there was a positive correlation. However, 40% said there was not. Move down to smoking. So again, these are papers that look specifically at smoking as a risk factor for non-union. You'll see there's 25 studies. 16 have positive correlation. So 16 of the 25 studies that looked at smoking as cause of non-union suggest that it is correlated. However, 9 that looked at smoking did not show a correlation. So unfortunately, this means some of the factors that we believe so strongly are associated with non-union, it's not supported by the literature. Again, that doesn't mean that they are or they are not. It's just the literature doesn't support it, which does make it challenging for us to instruct patients, and it makes it challenging for us to design perfect studies. Again, we could give you this slide, you can come back to it, but again, you can find your favorite factor as you go down, and we'll walk through a couple of these more closely. So we are arguing that there's a discrepancy that exists between the ambiguity of the orthopedic literature and the near unanimity in interpreting that literature. And I'll show you that graphically here in a second. We're going to look at age and smoking and diabetes and NSAIDs in particular. So we surveyed 335 orthopedic surgeons, and that's where I get where we're saying it was nearly unanimous. And then we're going to look at what the literature says, just to compare what we believe as surgeons to what the literature says. So when you look at age, 82% of the surgeons surveyed felt that age was a risk factor. The literature only supports it 61% of the time. We walked through that in the graph earlier. What we found here is that this was a variable effect by bone. It was a strong risk factor in the clavicle, but weak for the humerus. And age could be a surrogate for other risk factors. And this becomes an issue when we talked about the number of prospective studies. If there's just a few number of good studies on the humerus, do we have good data? Smoking, 98% of orthopedic surgeons that were queried said that it's a risk factor. However, only 64% of the literature suggests that it is a positive correlation. So there's a mismatch between what surgeons believe and what the literature supports. Doesn't mean one's right or wrong, but there just is a mismatch. Again, smoking is confirmed as a risk factor in 64%. We found papers that there's a positive correlation in the clavicle, the scaphoid, the scapula, the humerus, the tibia, and the femur. However, there are also negative studies that suggested no link between smoking and non-union in the tibia and the femur and the humerus. So you can see there's a problem here. In the tibia, there's 3 studies with 314 patients suggest a positive correlation, but 2 studies with 75% that suggest no correlation. And 36% of recent studies failed to demonstrate significant relation between smoking and non-union when you look at it that other way. That's impressive. Diabetes, again, 97% of surgeons felt it was a risk factor. The literature only supports it 71% of the time. NSAIDs, again, 86% of surgeons queried at this time. I think that number could potentially be lower now. It's only supported by 50% of the literature. Other risk factors that we see this issue in the literature: obesity, 75% of the time; alcohol, 80%; and osteoporosis, only 40%. So let's just look at that discrepancy for tibia just a little bit more closely. It's it's a case we showed earlier, and it is a difficult bone to get healed if things aren't going well. And I think if you look on the left, again, you can find those 5. Look at smoking. You'll find 5 studies for tibia. 3 of them were positive, but only 20% of those were prospective studies. So again, not a large number of studies in general, and a very, very low percentage, if you look at that 4th column, that were prospective. So we have poor literature looking at the tibia for non-union. And I'm going to argue the literature is actually very poor. It's worse than we may think, and perhaps this shows it. So again, this shows those same sort of risk factors in that left column: bone 1, bone 2, bone 3, bone 4, bone 5. It's just the most commonly studied bone for each of these factors on the left. So if you go down to smoking, you'll see that these are retrospective studies. There's only humerus and tibia being studied. But again, you can see obesity, very few studies; sex, very few studies; diabetes, very, very few studies. And those are retrospective studies. And then we move on to prospective studies. And again, I think you can see, if you just look down below, infection, smoking, obesity, sex, diabetes, alcohol, there's no prospective studies in our literature looking at non-union. So this is a real challenge for us. I think that we can't define non-union. We don't know its true incidence. The literature to guide us is actually extremely poor. We have some evidence, but again, it's very low quality. It's not a high level of evidence. So I think we could do better, and I think we need to do better. They asked, we did publish some on this, and we could present that in another format, but we're going to actually go on to look at some options for treating non-unions, even though it's been so challenging to define them. So how can low-intensity pulse ultrasound help? We're going to discuss the literature, the science, the impact of compliance. We'll look a little bit at costs, and we'll look at cases. And I'd like to look at this as both for the prevention of non-unions and the treatment of non-unions. And if I say LIPUS, again, that refers to low-intensity pulsed ultrasound as a bone healing device. Start with a quick case. This was a 27-year-old woman. She was healthy, and she'd been treated at another hospital in September of 2007. And then she relocated to where I worked, and she came to see me in February of 2008. So she's 5 months out, and locally, all her other fractures are healed, but her one humerus had not. And her local surgeon, who's a world-class surgeon, really is well known, had planned to revise the humerus. She was pain-free at the time, but again, they were planning another surgery when her husband got a new job and she relocated to where I was working. And here's some x-rays of her at 5 months out. Again, it's her left humerus. You can see that she's been fixed. She was fixed at the index injury. And that is just a magnified view of the fracture. You could be potentially critical that there's some screws near the fracture site. But again, I think expertly done, well aligned. But you can still see fracture lines quite clearly. Not a lot of callus formation, if much. Maybe some little sclerotic pieces of bone in there, but I don't think it's healed. Now, I'm not arguing this is or is not a non-union, but decide for yourselves if you think this fracture is going to change and go on to heal on its own, if this is the way it looks 5 months out. And I think that's why our local surgeon wanted to operate. And here's the lateral. And again, magnified view on the right, let you see it a little bit better. Again, I think we all would agree that at least 3 of the 4 cortices aren't aligned. I'm not sure we can see that well under the plate there to see that cortice, but I think the medial cortex isn't healed. I don't think the 2 cortices we see here are healed. So I think this is not healed. Is it a delayed union or non-union? I don't know that I know. So we discussed some treatment options with this patient. I ran an infection practice. We could take hardware out and get infection labs if we think that's a case. That's a bit of an extreme example. We could do a revision, ORIF, open reduction internal fixation. And again, that's what was planned for her locally. You could do a revision, ORIF, with shortening to get healthy bone ends together. Again, that would probably fall into very similar answers number 2. You could convert it to a nail. Perhaps you think nails would do better. You could just watch her, which is reasonable because she was stable and she wasn't hurting. Or you could try low-intensity pulse ultrasound, and we did discuss that with the patient. So we discussed revision, which was her local plan, versus LIPUS, and the patient really didn't want non-operative care. She was frustrated that she wasn't healed, but wasn't quite ready for surgery again. We checked labs to be sure that we didn't think infection was a potential issue here. Her SAID rate was 6, which was normal at our hospital. Her CRP, C-reactive protein, was 0.07, which was within normal range at our hospital. And her white cell count was 9.9, which again was normal for our local environment. So we didn't think by labs or by exam that she was infected. So I didn't think that that required any intervention. So the patient chose LIPUS, and that's the path we went down, and we saw her 4 months after that, so we're now 9 months out, and you can remember the way the fractures looked before, and this is the way she looked 4 months later. So between month 5 and 9, she used LIPUS for 20 minutes a day, and this was the biologic response that we saw. I don't know if that response would have happened without some intervention. That's your call. But again, you can see the AP there, and then the magnified view. Maybe still some fracture line present. There's the lateral. Again, you can still see the fracture line, but maybe some calluses on the cortices. I wasn't totally sure, and I like clinical union and radiographic union in my patients. And I wasn't convinced we had radiographic union, though she was doing fine clinically, so I got a CT. And that CT did confirm that she still had persistent fracture lines. So I didn't feel that I could tell this patient she was healed. She was improving, but not healed radiographically. This is what the CT read was, subtle but persistent lucency, without evidence of osseous bridging. So do we operate at this point? Do we continue LIPUS? We decided to continue with LIPUS as we saw a strong biologic response to it. Then I saw her 4 months later at 13 months post-op. And here's her final films. We felt that we had eradicated that fracture line, and we thought at this point we had both clinical and radiographic union. And we didn't have to proceed with more surgery for this patient. So what is low-intensity pulse ultrasound? It is just that. It is an ultrasound machine, not dissimilar from the one we use for diagnostics in the hospital, or it's not that different than the one used for therapy, other than the intensity is much, much lower when used for bone healing. And you can see this is the way it's pulsed, and you can see its frequency there. So it's a low-intensity ultrasound wave that's pulsed. This is just an example of the depth of penetration through soft tissue. So if you think of somebody's thigh and you need to get to a deep femoral nonunion or a deep femoral fracture, that represents the transducer on the left at 0 centimeters of penetration. And you can see that there's still an effect beyond 25 centimeters through soft tissue. 25 centimeters correlates to approximately 10 inches. So that's quite a thick soft tissue envelope that you can get through. And we all have patients that perhaps are a little thicker than that, but you can see that you still get an effect even beyond that 25 centimeters. This is just a photograph on the right of this model, and then a demonstration of the waves in this bovine tibia. And you see the ultrasound transducers at the top. You can see the waves of ultrasound coming down and contacting the outer cortex of that tibia. But what you also see is some of the waves penetrate the tibia and enter the medullary canal and would also get to the other side of the bone if this was not a transected tibia. The point being here that even if you need to choose a face of the bone where the nonunion may not be, there is sort of a shear wave that wraps around the bone, but also LIPUS that penetrates into the medullary canal and will give you an effect outside of just the area where the LIPUS is contacting the bone. And I think that's important if you start thinking about if we want to upregulate factors, if we want to stimulate cells, where are those cells located, and am I impacting it with LIPUS? Important to understand that there are no negative effects in the presence of metal implants. It's non-cavitating, it's non-thermal. Again, we talked about how low intensity it was. No metal degradation, and there's no effect on screw stability or torque removal. Now, that being said, it doesn't penetrate metal like it penetrates the tibia in the last slide. So it's important, if you have the soft tissue envelope to allow it, that you place your transducer in a way that the plate or the metal is not directly impacted to maximize your effect of the LIPUS. I'm going to walk through some of the clinical data for LIPUS. We're going to start with fresh fractures, and then we're going to look at nonunions. So this is the clinical data on indicated fresh fractures. This is Heckman's study from JBJS in '94. Remember about the level of evidences we were talking about earlier for non-union, and it's up to you to decide if you think these studies are well designed or not and what level they are. But this is a prospective, it's a randomized, it's a placebo-controlled, double-blinded, multi-center study. The fractures that were included were acute or grade 1 open tibia fractures. And I'll remind you, that was really Gustio's definition, that they were treating their grade 1s in the cast this way. So I think a very reasonable choice of fractures. It had to be short oblique or transverse fractures with less than 50% displacement. Again, quite reminiscent of Gustio's indications. And the patients either received a placebo or an active LIPUS, and they were treated for 20 minutes a day until healed. Definition of union was 3 cortices bridged and no pain on weight bearing or palpation. And I think it's important to remember when you look at the number of days here and compare it to our next study, but it's 154 days from the placebo-controlled tibias to heal, and that's what we would expect, probably 5 months or so for a tibia to heal. In the group, the 33 patients that received LIPUS, you can see they healed at 96 days. That was an acceleration of 38% in these tibia fractures. Now, this is Christensen's study. This is also in JBJS in 1997. This is a prospective, randomized, placebo-controlled, double-blind, multi-center study looking at fresh radius fractures. These are acute distal radius fractures treated conservatively, which I know is not always the way it's done today. And again, there's a placebo group and a treatment group, and the treatment group received 20 minutes of LIPUS per day until 3 cortices were bridged. And again, I am pleased to see the same amount of acceleration. You see 38% acceleration again, but the days are different, right? The distal radius heals quicker. They heal in about 98 days with placebo-controlled, healed at 60 days. So that's a month difference. Think about the impact on patients with that. It was 2 months or 3 months earlier in the tibia. There's the tibia again. Again, you've saved 60 days or so, so you saved 2 months there and a month with the distal radius in the groups that received LIPUS. Look at some non-union clinical data now, focusing on LIPUS. And again, we've made it clear and beaten the point home that it's very difficult to define non-union, very difficult to study non-union. So let's look at these studies and keep that in mind. Because of that difficulty in defining them and the rarity of them, if the chapter was right that it's 2.5% of the time, our study suggests it was 4.9% of the time, but again, it varies by bone. There's not all of us have a lot of non-unions. So this is Mayor's study. It's a prospective case series looking at 36 non-unions and 64 delayed unions, again, defined by the surgeons. But to be included, they had to be stable vital fragments. They had to have blood supply, no evidence of infection, could be atrophic or hypertrophic fractures, had to be at least 90 days since the last surgery or treatment change, and at least 120 days since fracture. These patients, the only change that these patients received was 20 minutes a day. And again, I think if you think back to the pragmatic definition of non-union, that this fracture won't heal without intervention, and you're defining some of these as non-union, you really can't get a placebo. It would be inappropriate to put to your IRB that I define this as a patient who needs something to heal, but I'm going to randomize them to placebo. You really can't do that. So all of these patients were treated, and all of these patients received LIPUS for 20 minutes a day. You can see overall non-unions, average fracture was 680 days, even though we said it had to be at least 120 days old. The average fracture was almost 2 years old. 86% of those non-unions went on to heal with the addition of LIPUS. Of the atrophics, 83% went on to heal. That was 84 fractures. And the hypertrophics, 100% went on to heal. Similar study here to the first. This is Nolte's study from Journal of Trauma in 2001. It's a prospective case series of 29 non-unions, 5 atrophic, 12 hypertrophic, 12 oligotrophic. Mean fracture age was 1.2 years. Mean time after the last surgery was 1 year. An average of 1.4 failed surgeries. And the only change of treatment was LIPUS for 20 minutes a day. And here you can see overall, again, 86% heal rate overall in all of these 29 non-unions. Of the smokers, 82% went on to heal, and those who never smoked, 100% went on to heal. Gebauer's study, prospective case series of 67 nonunions, inclusion had to be stable, no infection, at least 8 months old, at least 4 months since the last intervention, at least 3 months without radiographic healing. Their mean fracture age was 39 months of 3 years old. They had a mean of 2 failed surgeries. Only treatment change was LIPUS for 20 minutes a day, and again, you see 85% of those fractures went on to heal. So we're getting pretty similar results between these studies, 86, 86, 85. 89% of Gebauer's patients use the device, and I think that's an important point, that if your patients are not compliant with whatever treatment intervention you choose, it's going to be challenging for them to benefit from it. This chauffeur's paper is about as good as we can get in non-union, delayed union studies, in my opinion. I think we're near the top of the mountain here, and I'll explain why I think that. So this is a level 1 randomized controlled trial. So how can this be randomized? I told you earlier it would be inappropriate to randomize these. The reason this can be randomized is that these were delayed unions, not non-unions. So Chauffeur and his team, by definition in their area, at 3 months, if you're not healed, you're a non-union. But at the point when you become a non-union, they fell out of the study. The study ended. So if the patients went on to become a non-union, they then were given treatment. So they were not randomizing non-unions, they were randomizing delayed unions. And it was during that period that they were able to look at the effect of LIPUS. So that 101 patients with delayed union after tibia fracture, so that's after I said 3 months, so that's after 4 months. And they were randomized either LIPUS or sham for the period between being defined as a delayed union and when they would be defined as a non-union. And the study outcomes were to look at bone mineral density and bone gap. It was not union. This is what they decided to look at. And what they found in those after 16 weeks, the patients treated with LIPUS, randomized to LIPUS, they had a 34% increase in bone mineral density at the fracture site. And that was significantly different than the patients who were treated with the sham device. They also had a mean reduction in bone gap, which also favors LIPUS treatment. Important again to mention here is that they had a 91% treatment compliance rate. And we've said this already, if you're not compliant, you have no chance of it being effective. The current LIPUS device that's on the market had a change where a calendar was placed on it, and you'll see the blue one is the newer device. And with the older device with no calendar for the patient or the practitioner to follow, there was just a steady and gradual drop-off of usage. So that's compliance on the left and treatment days on the right. And sometimes these non-unions take a while to heal. But what you see with the new device, you really sort of plateau at about 80% of compliance. And I think 80% compliance for trauma populations is strong. Another paper that we put together on chronic non-union. So we define chronic fracture non-union as those fractures that were over a year out from injury. We felt that everyone would accept that definition, that a fracture that happened on an index day and now we're over 365 days out. I think most people agree that's when that non-union would be acceptable as being defined there. And we looked at the heal rate in a cohort of 767 patients with chronic non-unions. Again, this was based off of an FDA required prospective registry from 94 to 98. So the FDA reviewed these cases and reviewed the data that came in. There were over 11,000 patients in this registry, but the cohort of 767 non-unions that were over a year old is what we looked at. These patients' average number of surgeries was 3.1 surgeries before being placed in the registry. Fracture had to be at least a year old. And we recorded fracture date, treatment start date, treatment end date, and the outcome. A busy slide, I apologize, but you see when you look at all fractures, 86.2% of these non-unions over a year old went on to heal in all fractures. All closed fractures, about the same number. In fact, open fractures healed a little higher rate. You can pick your favorite bone on the left. We'll just go right down to tibia, which we've been talking about for much of today. 168 healed, 21 didn't. So 88.9% of the tibia fractures that were over a year old went on to heal with the just the addition of LIPUS. We found that the fracture age did not significantly affect heal rates. That bar on the far right is fractures that were over 5 years old. They were non-unions over 5 years old. LIPUS was added, and 83% of them in this registry went on to heal. So again, in our cohort of 767 patients, we found an 86.2% heal rate. We found an 82.7% heal rate in the 98 non-unions that were over 5 years old. Fracture age was only associated with a slightly higher risk of treatment failure. What was not linked was smoking, BMI, being open or closed, number of prior surgeries, number of comorbidities, number of prescription meds. And we'll look at this a little bit higher. Perhaps LIPUS makes those patients with some risk factors act more normal, act more like a normal patient without risk factors. No significant difference in heal rate by location or fixation type. This is Leighton's paper, again, a meta-analysis looking at the healing of fracture non-unions treated with LIPUS. They adhered to PRISMA guidelines. They found fracture age had to be at least 3 months in human trials with more than 12 patients. They had 13 studies that met their criteria. They had 1,441 non-unions, and their primary endpoint was heal rate. You can see the subgroup analysis that they performed, again, looking at age, smoking, prior without surgery interval, and number of prior surgeries. And what they found was an overall heal rate of 82% in this meta-analysis. What they found was that hypertrophic non-unions had a 2 times greater heal rate than all other non-unions. And you can see down below that a prior without surgery interval of less than 6 months was associated with a more favorable heal rate. So if you think about adding LIPUS, perhaps doing it earlier has some advantage. So this is a recent meta-analysis with strict controls and robust results. LIPUS had an overall treatment success rate of established non-union fractures of 82%, was more effective for hypertrophic non-unions and when used within 6 months after the last surgery. And they seem to be independent, heal rates seem to be independent of various factors commonly associated with delayed fracture healing, like smoking. LIPUS success rates were comparable to surgical intervention for established non-unions, so perhaps you have an option other than surgery for some of these patients. So let's look at smoking more specifically. I write here that smoking is a known risk factor in fracture healing. That certainly is what we believe as surgeons. Does the literature support it? We've talked about that quite a bit. Cigarette smoking does diminish vascularization at bone healing sites through the action of nicotine. So let's go back and look at that Heckman and those studies when we look just at the smoking. This is Cook's study. So when he looks at the tibia, again, you can see the smokers, when they receive placebo, they're at 175 days. If you recall, we're at 150 days in the whole study. So we've added another 20, 25 days or so. But with LIPUS, they heal 72 days faster. So that effect is magnified in the smokers. So the addition of LIPUS makes the smoking tibia fracture patients heal more normally. Heal like a patient who doesn't smoke. Same is true for the radius. Again, we're a little further out, 98 days. We had 50 days of acceleration in the smokers who receive LIPUS. One other factor here, this is the percentage of LIPUS-treated smokers who developed a tibial delayed union. So those were fresh fractures, if you recall. Those weren't non-unions. Those were fresh fractures. Of the 14 patients who received LIPUS, and were smokers, none of them went on to delayed union. They all healed. However, 6 of the 18 patients who smoked and did not receive LIPUS went on to delayed union. So again, none of the smokers failed to heal. So how does this work? We've talked some about the alphabet soup of bone healing, and you'll recall some of those cartoons from earlier on of secondary fracture healing. On the left, you see the transducer on the skin over the fracture site. You get nano motion, not micro motion. It's much smaller motion as the waves impact that fracture hematoma. You can see in that cartoon that the integrins on the cell surface respond, and they upregulate fracture factors such as BMP, VEGF, and so forth. And those factors are required for enhanced endochondral ossification. So again, just a brief cartoon of how this works. We'll go a little bit more into that here. Again, LIPUS sends its stimulation through the soft tissue in the skin to the fracture. LIPUS activates the cell surface. It activates these mechanoreceptors called integrins, and that initiates an intracellular cascade that leads to upregulation. What's upregulated? Cell differentiation is upregulated, converting stem cells to osteoblasts to make bone to affect healing. VEGF, new blood vessels, are upregulated by LIPUS. BMPs, a whole alphabet soup of those are upregulated that are essential to creation of new bone, and mineralization. We saw that in the Schoeffer study. Some of this is working through the COX-2 pathways that's critical for production of PGE2. Again, just talking more about mechanism of action, you'll see here, top left, angiogenesis. The dark blue is LIPUS. The control is in the tan box. You'll see increased angiogenesis, increased bone mineralization in the top right, increased VEGF down below, increased FGF. So again, you can see upregulation. So these are basic science studies that demonstrate that upregulation to you. This is just looking at risk factors and diabetes, in particular the LIPUS effect. So here we're looking at VEGF on the left and neovascularization on the right. So you see the control, and that's the amount of protein of VEGF that's there. And then you take a diabetic animal, and that's in the middle, and you can see that they are significantly less than the control. But you add LIPUS to the diabetic animal, and it's statistically no different than the control animal. So once again, we're seeing that with the addition of LIPUS, these risk factors are normalized. So this mouse is acting like a mouse without diabetes when LIPUS is added. Neovascularization, same sort of pattern on the right. The control, the diabetic animal, significantly lower. Add LIPUS to that diabetic animal, and it's normalized. So we see a magnified effect in the patients with high risk. And here again, we'll just see mineral deposition with the ultrasound treatment is magnified in this study. And mineralization of human fracture, human hematoma-derived progenitor cells. So again, so mineral in both animals and in human cells, you see an increased effect from LIPUS. Would you want to learn more about this? I'd refer you to this article by Harrison and his team, which walks through these studies much more in depth than we have time for here. Is there an economic impact on accelerated healing or treatment of nonunions by LIPUS? So this is Samir's paper. It's a health plan database study. Looked at matched patients with non-union surgery and LIPUS for non-union treatment. They looked at 12-month medical costs. They found 1,100 matched patients were identified. In the surgery-only patients, the medical costs were $6,289 higher than the LIPUS-only patients. So again, they looked at patients treated with and without LIPUS for the same injuries, and it costs more if they were treated without LIPUS. A lot of it has to do with the acceleration of healing. Now, the NICE group is a group that advises the National Institute for Health and Clinical Excellence in what was the UK. I don't know what we're supposed to call it post-Brexit, but for their health plan, their national health plan, NICE gives them guidance. I'm not calling it LIPUS here. This is actually the brand name Exogen, but that is because the NICE guidelines actually had specific guidance for Exogen. And their guidance for Exogen for the use on non-union fractures, their recommendation is that the case for adopting Exogen in UK National Health ultrasound bone healing system to treat long bone fracture with non-union, they define it as 9 months, is supported by the clinical evidence, and it shows high rates of fracture healing. So their recommendation is to adopt Exogen as the treatment for non-unions. They said that there was a cost savings from their information, and here it says Exogen ultrasound bone healing system to treat long bone fractures with non-unions was an estimated cost savings of £2,407, which would be more in dollars at the time this was published. And this is compared with the current management and by avoiding surgery. They also had recommendations for delayed union, that they thought there was some radiologic evidence for improved healing when the Exogen ultrasound bone healing system is used for long bone fractures with delayed healing defined as 3 months. I'm going to walk through one last case for the group, and then we'll hopefully finish up on time for you. This is a 69-year-old male, came to see me 7 months after his ankle fracture. He'd been treated in a boot, still had pain, been treated in a cast, still had pain. His local doctor had advised him to have surgery, but he came to see me. He was surgery adverse. This is a magnified view of the x-ray I got, and I wasn't sure if this was a radiographic non-union or not. This patient was clinically not healed. He was painful, but I thought perhaps there were some bridging cells there or some callus. I was not sure. I got a CT scan, and these are some selected images from the CT scan. I think it shows a couple things. One, clear fracture line, met my definition of non-union, but what worried me if I had to proceed with surgery is that there was endosteal sclerosis. Particularly if you look on that proximal segment of fibula at the fracture site, there's sclerotic bone there. So if I was going to proceed with surgery, I felt like I would have to remove that sclerotic bone, perhaps put bone graft in, perhaps get the fracture stabilized. And that would be a challenge to get in there to remove that bone. Patient, again, was surgery adverse. We discussed LIPUS as an option for the patient, and that's the path he chose. He came back and saw me 3 months later. So this is the change between 7 and 10 months. Again, that's a magnified view of the new x-ray now. I had planned on getting a CT scan for him because even when he first came to see me, I couldn't tell if he was healed or not. So we scheduled for a CT before he saw me, and what you'll see here is that CT scan. Again, what you see here is eradication of that fracture line, resolution of that endosteal sclerosis. That sclerosis has somehow been removed by activated osteoclast, and then the fracture, the non-union, has been bridged by osteoblast. So he went on to heal and was clinically asymptomatic when we saw him at that 10-month mark. So thank you very much for your attention. I hope it was worthwhile. I hope it was somewhat informative. You will be redirected back to your landing page, and you can complete a post-test and evaluation, and then you can download and print your certificate. And again, thank you for your attention, and have a great day.